nursing students, other students, participants. Yay, participants. Most of you know me. My name is Cari Shulkin, and I'm a nurse. I just retired from UC Davis. And the lecture today wanted to talk a little bit about chest pain or angina. So, anyone in the room ever had chest pain? Besides Linda 2 minutes ago? Anyone want to, yes, anyone want to share what were your symptoms when you were having chest pain? Go ahead, Kevin.
I was making oatmeal and I started to always feel weird and then shortness of breath and then kind of strange pain up the chest. I went and lay down for like 2 minutes and I realized this is when people way. So I get up and went in and told my wife, I think I need to go to the hospital. What? And so we jumped in the car and went there and we got there so fast that the enzyme that doesn't they register,
Yeah,
it's too low. So they told me I wasn't having a heart attack. But that I went to the bottom of the queue. And by the time they got back to me, then my enzyme was.
were you still having that pain?
Yeah.
That went across your chest? Okay.
So I was more worried about, it was right at the height of the Omicron COVID thing. I was more worried about the other patients who were waiting to get COVID than it was about my symptoms necessarily. Because I didn't want to add that on top. But it turned out to be a heart attack. And by 8 o'clock this morning, they put in the stent.
Wow. Wow. Thank you for sharing that. Anyone else have chest pain? Yes, Ron.
Major, but first the heart attack I had was on a golf course and it began to feel as though my whole chest was pressure. I don't know how you define pain. It wasn't pain per se, it was pressure. And I kept playing and I couldn't do it anymore. I said I've got to go somewhere. My friend took me to Mercy and they said I used 3 of my 4 hours up. And they put a stent in and I damaged most of my heart.
Yes.
Second one, like 20 years later, 4 years ago, with pain. There was the sharp pains up in here, and I took nitro and it took it away. Came back, Then I went in and I had another couple of things.
Wow.
So it's varying types of pain, but pressure was the main thing.
Yes. Okay. We need to hear from the women because the women usually present a little differently. Any women with chest pain? Well, we'll talk about that because we may have had chest pain and we don't even recognize it as angina because women are just so unique. Anyone else? John, you actually had a little bit of a story because yours was unique as well.
Mine is similar to Kevin in that I had been loading furniture for a yard sale of the neighborhood, and I came back feeling kind of winded, exercise that I wasn't used to doing. And I tried to lie down and sort of recapture the feeling, and I couldn't recover. It didn't feel right. And there's a sense in my head of this, and you've got to take care of this. And so I called my former wife and said, I need to go to the hospital. And she just happened to be getting in the car. So we went straight to the emergency room, and I figured, well, it's a chest pain. I haven't worked in the emergency room. They took me right in and they hooked up the leads to my arms and legs. And I was still in my shirt and pants, and she picks up the phone and says, get the second suite ready. And
boom.
So I folded my clothes, gave them to my daughter, and said, everything's fine.
But you had a stent.
I got a stent. Yeah.
Did you have a heart attack as well?
Yeah.
You know where you were in that 3 out of 4 hours? That's an interesting analogy.
What's that?
Ron said he was at the third of his fourth hour. I'm not sure what happens at hour
Well,
4.
from Davis to Sacramento,
Right.
the ride was horrible. I just thought, oh, I was leaning back, and the pain and the pressure, and my friend said, "Well, should I take you home?" I said, "No, I think just take me to the hospital." So,
Good thing.
Yeah, I was just told later that I had 10 minutes.
Right.
Yeah.
That if I had fiddled around and hemmed and hawed and get it second and third thoughts, that would have been a waste of time.
Right. Right.
I mean, first you start out a little.
Well, of course,
Yeah,
that's human nature is to be in denial. This can't be happening to me. Yeah,
Sort of ignore.
yeah. Or take an antacid.
Yeah.
Yeah.
and
Did you have chest pain, David?
Yeah, I had heart attack when it was that. I was partying. And then I was mowing the lawn and got home late and I had this familiar gas pee. I drink lunch, but it wasn't, I said, I'll get over it, whatever. Well, I tried to get to sleep and it just didn't feel right. And it wasn't not pressure like an elephant sitting on my chest. It was more like just gas. And I said, well, this is a different type of gas. It's not going away. This is not being very good. Told the roommate, she goes, if it gets worse, we're going to the hospital. Like, oh, don't worry about it. Just, I've been partying. It's a regular thing. And so 3 hours later, it was unbearable. It wasn't pressure. It was just that gas being different. And I said, okay, let's go take a look. What the heck? Let's just go down. Went down there, hooked me up, same way it's gone. And then they said, oops, you're having a heart attack. And I said, wow, so this is not bad. I'm gonna die. It's a nice way to go. No, going in the hospital. People are just moving to hear someone having a heart attack. And I was just going, wow, this is pretty good. And so, see, I tell you, he said I had a half hour.
Wow.
And not one of you took an ambulance. I think that's kind of interesting.
Oh,
Yeah.
In denial.
So, but interesting, I think that the recurring theme, everyone had a little bit different symptoms, but it was that little voice in your head, like, this is a little different. You kind of said the same thing, like, I just knew it wasn't quite the same. This is something that I need to have taken care of.
The same for I think it wasn't different, and I think it sort of illustrates it very well. This is a former faculty who had described it as very mild to me. I'm interrupting her. Like mild, and you thought, oh, did I do something weird? Did I do something different? But was not super alarmed by it. And this is a nurse, not super alarmed.
Worst patients.
Yeah. If doctor enough, she called another nurse, and this is of course happening at 11 o'clock at night, and she's trying to decide, do I go to bed? Do I go get this dealt with? And we eventually, with encouragement from her friend, and I don't know whether she's an ambulance. I want to assume so. I really want to assume so, but I'm not sure that was the case. And they had told her if you had waited, even another couple of hours. To the negative blockage.
Wow. So she bought herself a stent.
Yeah, she had been walking around on the trip, walking like 4 or 5 miles a day every day.
Yeah.
She just returned from this trip and felt great. No chest pain. No.
Yeah.
None of the plastic signs. It was very, very mild, but it was that sense of.
Yeah.
this is something.
And a lot of times women present differently, which I'll talk about. Yeah,
Mine
Dodie.
is more a story of how far we've come. 75 years ago, yesterday, my dad died of a heart attack. And I know that he had angina pain because mom would be at the edge of the chair that he was in. And the kids would be gathered around, afraid that he was gonna die there, but we didn't know what was going on. So the next morning, he said he just didn't feel well. He needed to go to the doctor and would my mom go with him? So she did. The doctor said, you're okay, you can go on to work. Went on to work, was a couple months away, and he walked to work. And he sold tickets for the Union Pacific Railroad. And he was waiting on a customer, he called his friend to come over to him and he was out and he's calling him.
75 years ago. Yeah.
So,
Right, right. They probably didn't have the same equipment that we have
Oh, they
today,
don't.
you
No,
know, to
no,
even just
that's
do an
what-
EKG to be able, yeah, wow. Thank you, guys. Oh, Nick,
Well,
Yeah.
I happened to be, out in the fields pheasant hunting when I had mine. I was pheasant hunting and, I started feeling, shortness of breath. I couldn't get a wind. And I knew something was strange happening to me. So I could breathe, I could take the air in, but I couldn't bring it out. So what I did, I fell to my knees and got on the ground and I grabbed some grass to try to get the carbon monoxide off the grass to get some air. And my friend saw me, he came over and said, "What's happening?" I said, "I don't know, something is happening." He said, "What you feeling?" I said, "I can't get my wind." So he reached in his pocket and he had a bottle of nitroglycerin. And he gave me, pulled out the nitroglycerin, gave me one to stick that up under your tongue. And he stuck it under my tongue and it helped. He said, "Come on, let's go." He grabbed me and put me over his shoulder, took me to the truck. We had to go about a mile out of the fields. Got me in the truck.
you had to walk a mile?
We had to walk about a mile. A long ways. He had another guy come and help me to take me out of the field because I couldn't walk. I didn't have any strength. in
Oh my
legs.
gosh.
And took me to the truck. Huh? Yeah.
You brought him, I said.
Yeah.
I'll never go without him.
Yeah. Eventually passed. He had it. Yeah, I didn't know he had any difficulties with his heart. Or anything like that, but he had been carrying heart nitroglycerin. And that was a big help.
Yeah,
So,
it probably saved your life.
oh yeah, yes, it did. Yes, it
It's-
did.
yeah.
It got me in the hospital. Time enough to check me out. see what's
Wow.
wrong.
Okay, so let's talk about chest pain. So what is my heart telling me? So I think even just from these stories that we've heard, you know, it was all kind of the same outcome, right? There was something going on with my heart. I knew I had to do something. We know people die of heart attacks. So we need to listen, right? We really need to listen to our hearts, because the first thing everyone wants to do is, it's not me. This isn't going to happen to me. It's probably indigestion.
Yeah.
You know, oh, I just worked too hard. You know, we're perfectly aligned with denial. So angina is chest pain or discomfort or pressure, or I feel like an elephant is sitting on my chest. It can be any number of things. It's caused when your heart muscle doesn't get enough oxygen-rich blood. Let me just tell you a quick story. When I was a nurse on E6 at UC Davis, and E6 was a telemetry cardiac floor. And so all the patients are on a monitor, and the monitor tech said, you know, go check your patient. He's having a lot of arrhythmias. And so I went in and I took his vitals and they were okay. And I was like, are you having any chest pain? He goes, no, I'm not having any. So I go back out and the monitor tech says he's having a lot of PVCs, which is a little concerning. So I went back in. I said, are you sure? You know, I took his vitals again. Everything was normal. He's like, no, I'm not having any chest pain. But boy, I feel like there's an elephant sitting on my chest. Now the nurse has chest pain. We run out and get, you know, the EKG machine. And so it's really all about how we ask our patients, right? We're only as good as our tools. And so our communication tools, that was a very good lesson for me, because it might not be chest pain. Patients don't know what angina is. But do you have the medical director that we work with, Dr. Capagoda, which this is his program, used to tell his patients, if you have any feelings above your belly button, I want to know. That's very, very broad, but those were patients that had some type of cardiac event. So angina is not a disease. It's a symptom of an underlying heart problem, usually, you know, coronary heart disease. Ischemia is when one or more of the coronary arteries is narrowed or blocked, and there's an interruption of blood supply. So that's just some basic stuff that we're going to talk about when we're having a heart attack. I have a really great YouTube video that I hope I can bring up.
Click on it.
Oh. This is it.
Like all other tissues in the body, the heart muscle needs oxygen-rich blood to function. The coronary arteries, which are wrapped around the heart, fill that need. In some conditions, fat can build up along the walls of the coronary arteries, reducing the supply of oxygen to the heart muscle. This buildup is called atherosclerosis. The three major risk factors of atherosclerosis are high blood pressure, high cholesterol, and smoking. This plaque can tear, causing the body's emergency repair system to rally. Blood components called platelets stick to the fat that is now exposed by the tear, forming a clot. The clot can completely block the blood supply downstream to the heart. Within a few minutes, muscle cells in the heart begin to die. This is a heart attack. The heart keeps beating but starts to lose its normal rhythm. If a larger part of the heart is affected, it can stop beating entirely. This is called cardiac arrest. Despite common misconceptions, a guy grabbing his chest and falling to the ground is not the typical presentation of a heart attack. Some people do experience the classic Hollywood heart attack, but the truth is, the symptoms of a heart attack can be much more subtle. Many heart attacks begin with only mild discomfort in the chest that intensifies over time. Other symptoms include pain in one or both arms, the neck, or the abdomen. Shortness of breath may accompany the pain, along with unexplained sweating. Time is critical in treating a heart attack. The condition can be totally reversible if diagnosed and treated early. Irreversible damage begins within 30 minutes of blockage, and half of deaths occur in the first 4 hours after symptoms begin. Doctors can perform an angioplasty to reopen the artery. Please watch my next video to learn more about this procedure.
Okay, so there was Heart Attack 101. How do I want to go back? Okay. Oops.
What's he gonna do?
It just said it's okay. Not advancing. Okay. So there's actually 4 types of angina. So what we're talking about is stable angina, unstable angina, microvascular angina, and Prince metals. So you guys heard of any of these terms before? Students in the back should, right? Okay, good, good. Any of you guys? Any of our participants? No? Okay. So let's talk about them. Okay, so stable angina. It's also called effort angina. Discomfort or having any kind of symptoms is usually associated with activity. Minimal or no symptoms at rest. And the symptoms usually disappear after you stop that activity. So I think of stable angina as, you know, a patient or a person mowing the lawn. And every time I get to that one area where I have to push the lawnmower up, I always have a little bit of discomfort. But when I'm done with that area, it always goes away. Like it's very stable. It's very predictable. I know what makes it, I know what brings it on, and I know that rest will make it go away because it's very stable. And as long as you know what it is, and your doctor knows what it is, and your cardiologist knows what it is, stable, if you're going to have angina, it should be stable. But what we know with heart disease is that there's progression. And it can progress to becoming unstable. And that's when it becomes very, very scary. Because unstable angina, sometimes it's called crescendo angina, meaning that the pain increases and it builds. It can occur at rest, like it's not associated with activity or exertion, just at rest. It can be very severe in an acute onset, and can result in an acute coronary syndrome, which is what we want to prevent. So unstable angina, at any given time when any chest pains or angina that you have moves from being stable to unstable, that is a big red flag, and that's your body telling you something, and it's not anything to ignore. It's a big red flag. Then there's microvascular angina. And when we're talking about that, we're actually talking about like a dysfunction with some of the microvascular structures of the heart. The microvessels may not dilate properly, reducing blood flow to the heart muscle.
Capillaries.
The microvessels may constrict temporarily, blocking blood flow. So now this isn't really necessarily in response to anything. It's just a dysfunction in the vessels themselves. Other underlying conditions, we may see people that have diabetes, hypertension, or high cholesterol have microvascular dysfunction. There's usually no arterial blockage, and the actual cause is unknown. And so we see this a lot of times with younger, healthier people, specifically women. And up to 50% of women who present with anginal symptoms and they undergo a cardiac catheterization, that's when they put dye up and they can see all the vessels in your, they can visualize the coronaries and they can see if there's any blockages. They don't have blockages. So women are the ones that we really need to kind of focus on. And then there's Prinzmetal's angina, or now we're talking about vasospasms. And it's a variant form of angina with normal coronary vessels or maybe minimal atherosclerosis. This angina usually happens between midnight and morning when you're asleep or resting, and affects younger, healthier people. And it's caused by a spasm of the coronary artery. And so let's just kind of review something. So if we have a blockage, we know what's happening just even from the video on what we know, because we're all very bright, is that when blood flow carrying, the oxygen-rich blood is blocked from reaching a certain part of the heart, that tissue, that part of the muscle is hurting because it's dying, right? And so that hurt is your angina. And so that blockage is a problem, or whether it's a crack in the plaque and then there's a clot, there's a blockage. But whether that is a physical blockage, clot, even having a muscle spasm. So if you think about any of your vessels having a spasm like this, it still can stop blood from flowing. And it can stop blood from flowing long enough to anything flowing downstream is not going to get that oxygen-rich blood, and it's going to be hurting, and it's going to eventually, that heart muscle can die. So it's serious business. I can remember we did have a young woman in her 40s who had a lot of vasospasms, clear coronaries. She went in and she actually had a heart attack. She went in and had a heart cath, and they were able to elicit some of those vasospasms in her coronaries and started her on like a calcium channel blocker, and she was good. Though she did have a heart attack, small one. People who have migraines and Raynaud's phenomena may have a higher risk of Prinzmetal's. And that is because those are conditions where you actually have vasoconstriction, right? With a migraine or Raynaud's. That was interesting. And so there's just a picture of, a vasospasm.
Vessels all carry the blood also.
Mhm.
They get it from the main artery and it spreads out.
Comes right off the aorta, really huge vessel. All those coronaries are just laying on top of the heart. And so I don't know if you noticed, but I just noticed just as we were preparing for this, in that video I showed you, it was all men. I don't know if you noticed that, but it was men. They were talking about men. And I want to talk about that distribution of pain when men have chest pain or angina. So, because women it's totally something different. So what's typical is kind of what you see on the screen right there. You know, it's kind of in the left part of the chest, can radiate down your left arm. It can be in your upper chest. It can be kind of substernal, radiating all the way up into the jaw, or up into a shoulder. It can be kind of gastric, you know, feeling the GI symptoms. It can radiate down both arms, again, up in the jaw, right in the middle of the back, which you don't think of that as being very typical. But again, if you're a cardiac nurse and if you're a patient that has cardiac risk factors and you have a history of heart disease, then you should know all of this. You should know and be kind of aware of having any type of pains anywhere if you've got a lot of risk factors or you've had some type of event. Okay, so let's talk about women's typical chest pain symptoms. Ha! There's nothing typical about any woman. Is that funny? Kevin, I heard that. So angina's symptoms in women can include feeling out of breath, fatigue, nausea, vomiting, abdominal pains. Sharp chest pain can happen. Once that extra demand for blood and oxygen stops, so do the symptoms. So let me just say, like, 50 years ago, when heart attacks were being studied, it was by male cardiologists because it was dominated by men, and they were the ones writing the textbooks. And so they were the ones saying, when a man comes in, because men typically have their heart attacks earlier, they're going to present like it's in your face. It's this pain in the chest. It's this pressure. It's a vice grip. They may have this cold, clammy, it's like these very obvious presentation to the emergency room. And what we discovered by the 90s is that a lot of women were dying at home of heart attacks because they would present to the ER with not that typical, I have an elephant sitting on my chest. They have fatigue. They have, maybe some nausea. They have just kind of these more vague symptoms. Now, again, they can have major chest pains as well, but a lot of times they have more insidious symptoms, and an ER doc will give them Mylanta and maybe an antidepressant or a Xanax and send them home. And more women were dying at home of a heart attack, right? And so in the 90s, there was a really big push, and we have a female cardiologist at UC Davis, and she's still there and she's amazing, Dr. Villablanca, who really was at UC Davis and kind of, I want to say in Northern California, maybe all of California, maybe national. She was the pioneer for really putting women symptoms on the map, that we're not like men because we're better, but we also we just present differently, right? And we don't want to die at home. So the word needs to be out there that women have different chest pains or symptoms. Let me finish my thought, okay? The other thing is, what do we do, women? What do? We are taking care of the house, we're taking care of our husbands and the kids, and we're taking care of dinner and cleaning the house, and we take care of ourselves last. And so we can explain everything away. So we're part of the problem as well, but not anymore. Go ahead, John.
had a mother who passed on this gene. And one of the things that strikes me particularly where you have women with the problem is people don't do an adequate history. If they had talked to my mother about her family history, they would have seen a long line of people dying of heart attack and stroke, mostly heart attack. And that it, with men coming in, they're younger and the doctor at the time was one of me, one of us. But it, and it's presenting as an event happening now. But even then, taking the history and being able to tell the person, no, it's good party. And it's get the history, find out
Yeah,
where does this come from? Is there any chance? And I know in recent years, I've gotten much better histories done by my primary care people and by the cardiology people who, the cardiologist I see whose residents come in, and I always send the resident in first to learn to do a history.
yeah,
Because if you don't find out if there are factors at play, then to rely simply on the symptoms is just.
100%.
Yeah, it's
100%.
heroin in a corner.
Right, right. You don't want to miss something. You don't want to send somebody home and then having them dying at home of a heart attack.
My mother passed away. She was 62. At the time, she died in her sleep. And at the time, her doctor was treating her for acid reflux. Didn't know that she had any heart problems at all.
Yeah.
She suddenly passed away.
What year was this?
This was in 1978.
Yeah. That's what was happening. Yeah. Okay, so let's review what we know. It's kind of like this whole timeline. So first of all, we're walking around and we're asymptomatic. We don't have any symptoms, but maybe we have some risk factors. And we start having some feelings in our chest, some anginal feelings, but we go to the doctor, we get a full workup and evaluation, and he sees some stuff that needs to be watched and get you on some lowering blood pressure medication and some, maybe a statin for your cholesterol, but everything is stable, right? If you have this anginal pain, we know what brings it on. We know what gets rid of it. It's very, very stable. But in time, that can become unstable. And when it becomes unstable, what we know is that blockages become more advanced. And the next thing down the line is a myocardial infarction, which is just a big word for a heart attack, where the blockage was big enough where blood flow stopped. Okay. And so if you survive that, good for you. But then now you have a damaged heart, and you could very well have heart failure, meaning that the heart muscle now is damaged and it's not pumping effectively, and your lifestyle may be very limited because of that. And then death. So we know that this is the timeline. And so we know early intervention can have a totally different outcome. We want to prevent that heart attack. We want to prevent that any damage to the heart muscle itself, because we don't want heart failure and then dying, right? So nurses in the back, thinking about that with their patients. You guys, be proactive with yourselves. Don't sit on it. Don't sit at home wondering, what should I do? Let me go real quick with treatment. So of course it's relief of symptoms, right? Because if you're not having any of that anginal pain, then that means, you know, that your heart isn't hurting, that there's enough blood supply. We want to slow the progression of the disease and reduction of future events like another heart attack or a stent or bypass surgery. Okay, so what are some of the medications? And so just by raising your hands, who's on any nitrates, like nitroglycerin? Okay. So that's very often treats, that's what saved your life.
Yes.
And what it does, it's just automatically dilates those vessels, makes the vessels very big. If there's a little bit of a blockage, it opens everything up so blood flow is restored. It also can give you a massive headache.
Yes.
Yes. But you know what? You don't die from that headache.
No.
You die from that chest pain, right? Nitrates are really, really important. Aspirin, and aspirin should only be taken if your doctor tells you that you need it, because the pros and cons of taking an aspirin every day is something that we need to look at the risk benefit ratio. But it reduces the ability for your blood to clot. So remember, if that plaque cracks, your body naturally just wants to send all kinds of platelets to form a clot on that bleeding plaque, which causes that blockage. So having an aspirin on board can prevent that clot formation by preventing, reducing the ability of platelets to form. Some clot preventing drugs like, there's a ton of them now. I think of Plavix. What else? What are some Eliquis? What are some of the medications that you're on to keep your blood thin? Xarelto, yeah. And then beta blockers. Love beta blockers across the board. Beta blockers just make you live longer, right? Sometimes they can be a little hard to tolerate. When I'm saying a beta blocker, I'm talking like metoprolol, your atenolol, any of your medications that end in lol. So who's on a lull? Look at, everybody's on a lull.
Laugh out loud.
Laugh out loud. What? Yeah, okay, so what do they do? That's a great question. So your heart has all these, let me make sure I get this straight, beta receptors, and they actually, like when you have adrenaline, it hits those beta receptors and it makes your heart race, and it makes your fight or flight go. I mean, you're ready, adrenaline does what adrenaline needs to do, right? Well, if you have a damaged heart, that might not be the best thing.
Right.
So a beta blocker blocks those beta receptors. It blocks it. So you may have noticed, like when you start taking a beta blocker, that your get up and go, got up and went. That it kind of feels like, and that usually passes in time. Some people can tolerate it better than others, but just being able to protect the heart from that adrenaline push, that adrenaline makes people live longer. Blood pressure as well. The heart beats more slowly with less force, thereby reducing blood pressure. It also relaxes the blood vessels and opens them up for a better blood flow. Does a lot of good things. And then of course your statins, any of your cholesterol lowering medications. They may help your body reabsorb cholesterol that has accumulated in plaque in your artery walls, helping prevent further blockage in your blood. Statins do a lot of things. They can actually kind of stabilize plaque as well. Statins can be a really good thing.
Anti-inflammatory food.
Mm-hmm. Yes.
Was one of Dr. Casey's favorite information.
Yes, absolutely. And then there are calcium channel blockers. They relax and widen blood vessels by affecting the muscle cells in the arterial walls. Calcium channel blockers are a really good medication for anyone who has those vasospasms. That will prevent vasospasms. Okay, let's just take a minute. Does anyone have any questions? Comments? Concerns?
You
Yeah.
mentioned something about taking aspirin. If I remember correctly, it was never a good thing to take aspirins if you felt like you was having a heart attack.
Right. Right.
Never.
You may be on a aspirin if your doctor has prescribed it, because they know. Remember 10 or 15 years ago, they would say, you know, if you think you're calling 911, choose some aspirin.
Mm.
You should not, you should only do it under your doctor's order. Depending on, you know, you don't want to die of a gastric bleed if you're not having a heart attack, right? Because it's going to stop platelets forming everywhere. So bleed is a concern. So the doctor will determine whether or not you need an aspirin. Now, I don't know if you're going in the ambulance, if they have you take an aspirin or not. Anyone know that?
Right.
Okay, okay. So tests to diagnose heart disease. So, you know, we have blood tests, you can do chest x-ray, but here's some other things. Of course, just an EKG. And if you come into the ER with any type of pains, anginal pains, they're going to hook you up to an EKG and they'll be able to see if your heart is having an issue, if there's not enough blood getting to a certain part of your heart. A Holter monitor. Any of you guys had a Holter monitor or just a monitor that you can go? You've had a lot of cardiac stuff. It's a monitor that just records your rhythm. Now, it used to be a box that you would wear with a ton of wires. Now it's just this little taped thing to your chest that sends your rhythms to the office. And it's just looking for any arrhythmias or fast rhythms or slow rhythms or life-threatening arrhythmias.
My brother had 3 younger brothers, and the third brother has a pacemaker defibrillator, and every night it calls in
Yeah,
with us through his cell phone and just reports all the data,
it's amazing.
and then they send software updates over the phone, and it updates his pacemaker defibrillator while he's sleeping.
Will it charge his iPhone too?
Will deliver your pizza.
See,
You're good, then it'll deliver your pizza.
for all of us, it's like great technology, but for the nurses of the future, that's like, yeah, that's what they have out there now. It's really kind of pretty amazing. Echocardiogram, that's just the ultrasound. They can really look at structure and function of the heart. It's not invasive. It's just an ultrasound. Cardiac catheterization. So who's had a cardiac cath? That's when they kind of go in either through the groin, maybe, and a cube or wrist. And they're going to visualize. They're going to visualize your coronaries, but while they're there, they can place a stent. So who bought one of those? Not as much. They didn't ask, they just gave it to you. So how many people? A few. Were you raising your hand or just scratching your ear?
Me?
Yeah.
No, I'm having it.
Oh. So a cardiac catheterization is the most definitive way to see what is going on in those coronaries. It's very definitive because they put that dye down and they can see exactly what percentage of a blockage you have. Now, if you're going in because maybe everything is super clear, there's no blockages at all, but they know that maybe you're a younger, healthier person, they may try to elicit a vasospasm, right? And see if they can create a vasospasm and then try certain medications to make that vasospasm go away.
So is that the test where they give it to you and feel like they have to do that?
Oh, I don't know, but I
No,
think of it as
it's a
being
dye.
very flushed,
Yeah.
but I don't know. I haven't really heard patients say
So-
that they have to.
Because I have a friend who went and he said they gave it to him and it felt like he just eliminated all over the.
Oh, it is a warm feeling.
Right.
You know what? It is kind of a warm feeling throughout your body, and it may have that sensation.
Well, he was apologizing.
Oh,
I'll clean it up. They're like, no, it's just feeling it.
yeah.
So,
Yeah.
and that's what I was worried about when they were doing all the tests. Are they gonna give me this test? And I'm gonna have- So I go in and it was more like a shot of tequila. And so I told him that and he's like, "Well, I wanted that.
Tequila. Also, CT scans and MRIs is something else that they can kind of look at structure and look at blockages that way as well.
It's kind of fun to see them go through the layers of your
Yes. Yeah.
joints.
Yep. So let me go back. John mentioned, a history and physical is really, really important. And if someone who's just has a bunch of risk factors for heart disease and is first time seeing their doctor, it really is, they're not going to just automatically give someone a cardiac cath because it's super invasive, right? So that history and physical is really, really important. It's like putting the pieces of the puzzle together and really knowing what questions to ask and to really get that detailed history and a really good physical exam to put the pieces of the puzzle together to know what test should be next. So 911, why? Close to 1 million heart attacks that occur annually in the US, 659,000 result in death. Many more patients who survive their heart attacks do so with chronically damaged hearts. And I thought it was interesting, no one went by ambulance. So let's talk about that. Time is muscle, right? That's what the video said. And do you know what that means? That means that if you're having some symptoms, if you're having anginal pain, then that means blood is not getting to a certain part of that muscle. And those minutes of not having enough blood flow is damaging more and more muscle, right? So time is muscle. So call 911. Don't call a friend. Don't call the cardiology clinic. And don't call here. Don't call Linda. And don't drive yourself to the ER. I love that. So calling 911 is almost always the fastest way to get life-saving treatment because they're bringing the hospital to you. You don't have to drive, or your spouse doesn't have to drive, who's not going to be able to help you if you're having a heart attack and then you pass out. Now who's at risk? Everyone's at risk because they're going to be driving like a bat out of heck, right? So if you call 911, you're bringing the hospital to you because they've got medications, they've got a defibrillator, they've got things that you need that can keep you alive.
And train the people to know how to
Train people to revive you if needed. Yep. So if blood flow is not restored, you have that anginal pain, heart muscle within 20 to 40 minutes can have irreversible death of that heart muscle. So 20 to 40 minutes, that's when, you're going to get into some trouble. The more heart muscle that is saved, the better the chance of your survival, right? Angioplasty, or getting that stent or opening up those vessels, restores that blood flow. So when you go to the ER, there's a time frame of getting you into that cath lab to get that vessel open that give you the best chance of surviving. So be good to your heart. It's the only one you have, right? So what? Yeah, it's a bear to get a heart transplant. So what questions do you have for me?
Do they have an age limit where if you need a heart transplant, they're just saying no?
I don't know of that.
Well, I mean, you have to meet certain health.
Yeah, oh yeah, there's a whole criteria. Yeah.
I've been told 70,
70 is the cutoff?
and when I hit that, I said, well, maybe a little longer. You seem to be well enough to withstand, but apparently it had been 65, and then they bumped it up to 70 because they figured that people had deteriorated so far over life.
Yeah.
3 years or whatever.
Yeah, that kind of makes sense.
But we are living longer for.
Right, exactly.
What's the criteria?
Oh,
And to have a
I'd have to look that up. Sharon, do you know? What is the criteria for a heart transplant? I know you can't smoke. That's the one thing I know, because I was the smoking cessation person at UC Davis. And we would get all these transplant people needing to quit before they could get their kidney or their liver. They were not heart
You have to be
transplants.
pretty debilitated and like you have to have a functional capacity is really low. In the 3 or 4 met level, that's one of the criteria.
We can look it up for you. Yeah. Yep.
I have a younger cousin who had a heart transplant about 12 years ago. And he's doing fine.
You know what? We had a gentleman in the cardiac rehab, our reversal program, who he had 2, right? Larry? And how many years was Larry around?
Long time.
Fif-
Second was a long time.
Yeah, it was amazing. Yeah. He did. Yeah, he really did. Any other questions, comments?
Symptomatology would be based on whether it's arterial or vascular,
What's your,
whether the blockage is arterial or vascular. It's in the artery, in your aorta. Major problem. It's out in the vascular part, you might feel something.
your,
Not-
the symptoms presenting are basically the same, that you're gonna have anginal pain. So when I say anginal, I'm not gonna say, it's just so, it's a broad statement, but you're gonna have feeling somewhere above your belly button. Yeah. Thank you, everyone, RN students, other people, students, thank you.
This is almost something that should. be
Thank you.
People who
Thank
have
you,
not
Karen.
had heart involvement, who have just turned 50,
Yeah.
Yeah.
because we've been there
What's that?
and we made the
Just
trip.
right now, yes.
And so it's